Good morning, everyone. Like all Mondays, now we are here today with the GCRI team, GCRI Ahmedabad. They have a dedicated MD Palliative Medicine program, and the team will speak about approach to adult patient presenting with breathlessness in palliative care settings. So it's again a very important situation where we find in day-to-day practice that patients at least 70 to 80 is at least 30 to 40% patients they are presenting in advanced stage, and we are how to manage this situation. So for this, I think today is there is a dedicated team of GCRI Ahmedabad. The speaker is Dr. Akshay Tabiyar.
Yes,
He is first year junior resident of MD Palliative Medicine. Uh, his area of interest is hematological malignancy. So it's good that in first year he has planned and he has thought and he has given this area of interest, because in first year junior residency it's very difficult to find out area of interest, and but he has decided that he will be working in the hematological malignancy. And the moderator for this seminar is Dr. Varun Yadav, who has already finished MD Palliative Medicine and working as a senior resident in Department of Palliative Medicine. And he has published a good paper on in IJPC, prevalence of delirium in advanced cancer patient admitted in hospice setting and outpatient after palliative intervention. Very good. So please, Akshay and Varun, please go ahead. We will take up the question and answer at the end. Please write down your question and answer in the chat box. Thank you. Thank you. Go ahead.
good morning, all of you. I am Dr. Akshay Tabiyar, resident doctor at Department of Palliative Medicine at GCRI, BJ Medical College, Ahmedabad. Today's topic is approach to an adult patient presenting with breathlessness in a palliative care setting. Topics we will cover: first is definition, prevalence, pathophysiology, evaluation, and cause and then management. Definition. First is the American Thoracic Society explained that the experience of the dyspnea is a subjective experience of breathing discomfort that consists of the qualitatively distinct sensation that varies in the intensity. The experience derived from the interaction among the multiple physiological, psychological, social, and the environmental factor may induce the secondary physiological and behavioral response. Prevalence. Highest prevalence in the COPD is 90 to 95%, lung cancer 62 to 95%, heart disease 60 to 88%, dementia 70%, ALS 47 to 50% prevalence, and the in the no cardiorespiratory disease like the cardiac failure or the respiratory disease can cause the breathlessness in 45 to 81% of patients. Stroke 37%, renal disease 11 to 62%, and AIDS 11 to 62%, and in the cancer 10 to 70% prevalence is there. Pathophysiology include the two. First is the central nervous neural control, which controls the inhalation and exhalation by the pons and medulla. In the pons, we have two center, apneutic center, apneustic center, and pneumotactic center, which control the speed of the inhalation and exhalation. Medullary group, which have dorsal and ventral group. Dorsal group control the inhalation and airway defense, and ventral group control the exhalation. Bode-Zinsser complex control the respiratory rhythm. And sensory input, which control the depth and rate of the respiration. First is mechanoreceptor, provide the sensory information to the respiratory center of the brain, regulate the mechanical status of the lung and the chest wall. Metaboreceptor stimulate the breathing during the exercise. Peripheral chemoreceptor, which monitor the partial pressure of the arterial O2 and respond to the hypercapnia or the acidosis. Central chemoreceptor sense the pH changes O2, CO2, and the concentration in the brain. The central chemoreceptor located into the medulla is sensitive to the high level of the CO2. Peripheral chemoreceptor located into the carotid bodies and aortic bodies stimulated by the low level of the oxygen. Mechanoreceptor, which is present into lung and chest wall, stimulated by the acute and chronic condition, which all these three stimulate the brainstem respiratory center and causes the increase the respiratory drive and produces the breathlessness. Anxiety and emotion is directly stimulate the respiratory center and increase the respiratory drive and produces the breathlessness. This is the breathing, thinking, and functioning clinical model for the breathlessness in the chronic respiratory disease. First is breathing. Increase the respiratory rate, use of the accessory muscle and dynamic hyperinflation, which causes the insufficient breathing, increase the work of the breathing, and causes the breathlessness. Second domain is thoughts about thinking. Thoughts about the dying, misconception, attention to the sensation, memories, and the past experience, which causes the anxiety and depression and produces breathlessness. Third is functioning. Reduce the activity, tendency to self-isolate, more help from the other, which causes the deconditioning of the limb and chest wall and the accessory muscle and produces the breathlessness. Cause of the breathlessness. First is respiratory manifestation due to the malignant cause. First is lung cancer, secondary to lung, pleural effusion, superior vena cava obstruction, pulmonary embolism, pericardial effusion, major airway obstruction, lymphangitis, carcinomatosis, radiation-induced pneumonitis, and drug-induced pneumonitis, and chest infection. And then after shift to the non-respiratory manifestation of malignancy like the cancer cachexia, ascites, and gross hepatomegaly. Cardiopulmonary cause for the breathlessness is COPD, bronchiectasis, congestive heart failure, arrhythmia, and in the systemic cause, which causes the breathlessness is first is muscle weakness, motor neuron disease, muscular dystrophy, anemia, acidosis, deconditioning, and the respiratory panic attack. Assessment of the breathlessness. First is time course, acute, subacute, and chronic, severity according to mild, moderate, and severe. Associated symptom like chest pain, pleuritic, or the central or the referred, palpitation, syncope, pedal edema, fever, weight loss, night sweat, cough, change in the pitch of the voice, hemoptysis, dysphagia, and anxiety. Positionality, orthopnea, platypnea, and trepopnea. Pattern of the dyspnea is seasonal, occupational, past medical history, social medical history, and the drug history. Investigation we will do. For first is hemoglobin to rule out the anemia, glucose, blood urea nitrogen, and electrolyte to rule out the comorbidities and metabolic causes, thyroid stimulating hormone to rule out the hypo and hyperthyroidism, and pulmonary function test, DLCO, and spirometry to assess the lung function, pulse oximetry for the hypoxemia, chest X-ray, ECG, and echo for the cardiorespiratory abnormalities, and plasma BNP or the anti-pro BNP for the heart failure. Measurement of the breathlessness, which we can use different tool for the measurement of the breathlessness. First is a visual analog scale, revised Edmonton symptoms assessment scale, memorial symptom assessment scale, modified BODE scale, cancer dyspnea scale, modified medical research council scale, oxygen cost diagram, BODE means body mass index, airflow, obstruction, dyspnea, and exercise. This is visual analog scale, rating from 1 to 10. 1 means no breathlessness, 10 means extremely breathlessness. This is revised Edmonton symptom assessment scale, which contain the pain, tiredness, drowsiness, nausea, lack of appetite, shortness of breath, depression, anxiety, well-being, and other problems like the constipation, which grading from the 0 to 10. 0 means not any symptoms, and 10 means worst possible symptom. This is memorial symptom assessment scale, which include the difficulty in concentrating, pain, lack of energy, cough, change in the skin, dry mouth, nausea, feeling of drowsy, nausea, tingling in the hand and the feet, difficulty in sleeping, feeling bloated, problem with the urination, vomiting, shortness of breath, diarrhea, sweat, mouth sore, or problem with the sexual interaction or the activity, itching, lack of appetite, dizziness, difficulty in swallowing, change in the way food taste, weight loss, hair loss, and constipation, and the swelling of the arm or legs, which grading from the 0 to 4. 0 means not at all, and 4 means very much. This is modified BODE scale, which is a scale from the 0 to 10. 0 means nothing at all, and 10 means maximum dyspnea. This is cancer dyspnea scale, which is include the 12 question, which is rated from the 1 to 5. No, 1 means not at all, and 5 means very much. This is modified medical research council scale, grade from the 0 to 4. 0 means only get breathlessness with the strenuous exercise. First is short of breath when hurry on the level ground or walking up a slight hill. Second is on the level ground, I walk slower than the people of the same age because of the breathlessness, or have stopped for breathing when walking on my own pace. Third is stop for breathing after walking about 100 yards or after a few minutes on the level of ground. 4 is I am too breathless to leave home, or the I am breathless when dressing. This is oxygen post diaphragm. Patients are asked to identify the level of activity they are unable to perform due to the dyspnea. The scoring is brisk walking uphill 95%, medium walking uphill 75%, brisk walking on the level ground 69%, heavy stopping 58%, slow walking uphill 57%, medium walking 47%, bed making is 42, light shopping 36, washing yourself 27, slow walking on level ground 27, standing 21, sitting 17, and sleeping 7. BODE, body mass index, airflow, obstruction, and dyspnea exercise. Based on patient FEV1, distance walked in 6 minutes, MMRC dyspnea scale, and the BMI, we can grade from the 0 to 3. According to 0 to 3 the score, we predict the mortality of the patient 12 month, 24 month, or the 52 month. Then after, shift to the treatment of breathlessness. First is specific disease management for the underlying cause. Second is non-pharmacological intervention. Third is pharmacological treatment. Fourth is non-invasive ventilation. And fifth is palliative sedation. Specific disease management for the underlying cause. First is malignant cause of lung cancer. Chemotherapy in selected patient, molecular targeted therapy for the adenocarcinoma of the lung with the epidermal growth factor receptor mutation. Secondary to lung, systemic therapy guided by the primary site, excision of the solitary metastasis in the highly selected patient, pleural effusion. We can do the repeated thoracocentesis, chemical pleurodesis with the TAC 90% efficacy. Thoracoscopic pleurodesis more effective than the medical pleurodesis. Indwelling of the pleural catheter, especially in the trapped lung. Superior vena cava obstruction stent 95% have relief and the faster. Chemotherapy and radiotherapy for the 60% in the non-small cell lung cancer. Trial of the steroid and the diuretics. Pulmonary embolism, low molecular weight heparin is more efficacious than the warfarin. Pericardial effusion, pericardiocentesis, catheter drain, pericardial window, or the pericardiotomy we can do. Major airway obstruction or radiotherapy, bronchial stent, endobronchial treatment like the laser therapy, cryotherapy, and trial of the glucocorticoid. Lymphangitis carcinomatosis, radiation-induced pneumonitis, and drug-induced pneumonitis, we can try glucocorticoid. In the chest wall infection, antibiotic according to sensitivity. Non-respiratory manifestation of malignancy. First is cancer cachexia, prevention of the aspiration. In ascites, we do the abdominal paracentesis. For the gross hepatomegaly, we use the semi-recommended position. Cardiopulmonary cause, COPD. Non-pharmacological therapy, first is breathing exercise. Then after we use the inhaled short-acting bronchodilator, inhaled long-acting bronchodilator, beta-2 agonist, anticholinergic, inhaled steroids may be useful. Bronchiectasis, airway clearance, antibiotic for the infective exacerbation. Congestive heart failure, angiotensin converting enzyme inhibitor, beta blocker, hydralazine plus with the nitrates or angiotensin receptor blocker and spironolactone may be useful. Digoxin and diuretics is also useful in congestive heart failure. Arrhythmia, in the arrhythmia, we use the antiarrhythmic agent to relieve the breathlessness. Systemic cause of muscle weakness, motor neuron disease, and muscular dystrophy. We use the non-invasive ventilation. For the anemia, we do the blood transfusion or the give erythropoietin. Acidosis, sodium bicarbonate, we can give deconditioning. For this patient, we use the exercise. For the respiratory panic attack, anxiety management, we should do. Treatment for the underlying cause, management of the dyspnea in the advanced cancer OSCO guideline. Patient with the potentially reversible common etiology of the dyspnea like the pleural effusion, pneumonia, airway obstruction, anemia, asthma, chronic obstructive pulmonary disease, exacerbation, or the pulmonary embolism. Treatment-induced pneumonitis should be give concordant treatment consist with their disease prognosis and overall health status. Patient with the dyspnea because of the underlying malignancy like lymphangitis, carcinomatosis, atelectasis because of large pulmonary mass and malignant pleural effusion may be benefit for the cancer-directed treatment if consist with their wish prognosis and overall health status. Patient with the underlying comorbidities such as COPD and the heart failure should have management of these condition optimized. Non-pharmacological measure, as previously discussed with this thinking, breathing, and functioning model, we manage the patient according to this chart. First is breathing. First is use the breathing technique, hand-hold fan, airway clearance technique, inspiratory muscle training, chest wall vibration, and non-invasive ventilation we use for the breathing technique. And then after thinking, we do the cognitive behavior therapy, relaxation technique, mindfulness, and acupuncture to relieve the thinking domain. Third is functioning, pulmonary rehabilitation, actively promotion, walking aids, pacing, and neuromuscular electrical stimulation, which reduces the breathlessness in functioning domain. Then after breathing training, pursed lip breathing, diaphragmatic breathing, and as blow you go, and position and pacing technique, which reduces the breathlessness. Pursed lip technique, as in shown is below image. Inhale slowly through your nose, and then after purse your lips as you would whistle, and then after exhale slowly while keeping your lips pursed. Pursed lip breathing decreases the dyspnea and the work of the breathing, decrease air trapping, collapse of bronchioles, and the CO2 tension, decrease the respiratory rate and accessory muscle use, increase the tidal volume and oxygenation, and exercise tolerance. Then after shift to the diaphragmatic breathing, initially used in supine, usually initiated in the supine position. Patient placed on one hand over the abdomen and other on the thorax just below the clavicle. Breathe deeply through the nose with distancing the abdomen forward while the movement of the rib cage kept to the minimal. Small weight can be placed on the abdomen. During the exhalation, the hand on the abdomen should be compressed and exhalation should be via the pursed lip. This combination decreases the respiratory rate and the co-coordinate the breathing pattern and improve the blood gases. Benefits of the diaphragmatic breathing is increase the tidal volume, decrease the functional residual capacity, and increase the maximum oxygen uptake. Position to reduce the breathlessness, relaxed sitting, forward lean standing, backward lean standing, forward lean sitting, and high side lying can reduces the breathlessness. Use of the fan 15 centimeter or the 6-inch away from the face, cheek, nose, and mouth area send a message to the brain which reduces the feeling of the breathlessness. And several studies support to hypothesis that stimulation of the trigeminal nerve V2 branch has central inhibitory effect on the dyspnea. The effect of the oxygen may be attributed to sensory stimulation, might be duplicated by the application of the cool moving air to the face. Study the immediate effect of the fan therapy in the terminal cancer with the dyspnea. At the rest, a meta-analysis suggests that the blowing fan over the face reduces the dyspnea in the terminal cancer patient. Walking aid, wheeler, walker, and a rotaler are helpful to relieve the breathlessness. Neuromuscular electrical stimulation, chest wall vibration modify the respiratory sensation by the activation of the muscle spindle in the intercostal muscle. Exercise has been shown to be effective in the COPD, but evidence for the advanced cancer is less clear. Acupuncture and acupressure, various intervention including the relaxation, muscle, music, and counseling and support with the breathing relaxation training, case management, and psychotherapy are frequently practiced. Pharmacological measure to optimize pre-existing therapy in the non-malignant disease. These are methods which can reduce the breathlessness in non-malignant disease. First is use of the bronchodilator, short-acting bronchodilator, long-acting bronchodilator, long-acting anticholinergic, inhaled corticosteroid, phosphodiesterase 4 inhibitor, theophylline, and diuretics for the heart failure. That all this medication reduces the non-malignant breathlessness. Use of the glucocorticoid. We can use the glucocorticoid in COPD exacerbation, tumor related to SPCO, anaphylaxis, bronchospasm, upper airway edema, steroid responsive malignancy like lymphoma and thymoma, reduce the radiation-induced, chemotherapy-induced pneumonitis, pulmonary lymphangitis, carcinomatosis. Evidence is largely based on the clinical experience. Dexamethasone is preferred drug for the these conditions. Opioids, low dose systemic opioid have placed in the systemic management of the breathlessness in the patient with both malignant and the non-malignant lung disease. Systemic opioid should be offered to patients with the dyspnea when the non-pharmacological intervention are insufficient to provide the dyspnea relief. Evidence quality is low and strength of recommendation is moderate from the ASCO guideline. Mechanism of opioid in the breathlessness: decrease metabolic rate and ventilatory requirement, reduce the medullary sensation to the hypercarbia or the hypoxia, blunted medullary response to the hypercarbia or the hypoxia, alteration of the neurotransmitter within the medullary respiratory center, cortical sedation, suppression of the respiratory awareness, analgesia, reduction of the pain-induced respiratory drive, anxiolytic effect, blunted afferent transmission from the pulmonary mechanoreceptor to the CNS, vasodilation, improve the cardiac function. Opioids can suppress the multiple step in the respiration to cause the respiratory depression. Opioids can affect on the pons medulla, central and peripheral chemoreceptor and mechanoreceptor, by which they can reduce the breathlessness. Opioids effect on central neural control. Opioid interact with the receptor located throughout the respiratory center in the brainstem, which under certain circumstances may be suppress various component of the respiratory drive. This picture shows the mu receptor present into pons and medulla, which can suppress the breathlessness. Then after shift to the morphine. Oral starting dose is 5 milligram 4 hourly, safe for the opioid naive patient with needed dose is 1/10 of the 24-hour dose. Switch from the weak opioid to morphine dose 10 mg 4 hourly with needed dose is 1/10 of the 24-hour dose. Subcutaneous administration in the opioid naive patient, continuous subcutaneous infusion start with the 20 mg 24 hour and 5 milligram subcutaneous as well as required. Patient already taking morphine 30 mg per oral BD is equal to 60 mg in 24 hour per oral divided by the 2. is equal to 30 mg in 24-hour continuous subcutaneous infusion. As needed dose is 1/10 of the 24-hour dose is equal to 3 to 5 milligram subcutaneous dose. Intravenous route in the opioid naive patient, give the prophylactically IV metoclopramide 10 mg. One ampule contain the 10 mg of the morphine diluted in 10 ml of normal saline. Inject the 1 ml morphine every 10 minutes until patient is pain-free or the complaint of undue sedation. Example, cumulative effective IV dose is 9 milligram. Intermittent injection dose is 9 milligram into the 4 hourly, around the 10 mg. Continuous IV infusion line, total daily dose is 9 into 6 is equal to 54 mg in 24 hour. Round is up or down to convenient number of the ampoules. Example, 50 mg or 60 mg. As needed dose is 5 to 10 mg. Once the effective regular dose is determined, an oral sustained release formulation can be substituted for the patient convenience. Effect of the regular low dose extended release morphine on the chronic breathlessness in the chronic obstructive pulmonary disease. The randomized clinical trial conclusion and the relevance among the people with the COPD and the severe chronic breathlessness, daily low dose extended releasing morphine did not significantly reduce the intensity of the worst breathlessness after 1 week of the treatment. This finding do not support the use of this dose for extended release morphine to relieve the breathlessness. Management of the breathlessness in palliative care, inhalers and dyspnea, or literature review. Result, isolated bronchodilator can be effective in the dyspnea management. However, the combination with the opioids leads to 52% reduction of the dyspnea, demonstrating efficacy of their combined use. There is role of the conventional inhaler not only in the patient affiliated with the chronic obstructive pulmonary disease, but also in those where obstruction is reversible and case of the dyspnea not yet diagnosed. Oral modified releasing morphine for the breathlessness in the chronic heart failure, randomized placebo-controlled trial. Oral morphine, oral oxycodone, and the placebo were given for the 4 days each, followed by the 3-day washout and the crossover. Breathlessness severity was reduced for the baseline with the all three intervention, with no statistically significant difference between the two active intervention and the placebo. Conclusion, morphine should only be prescribed in the population where other measures are unhelpful and with early management of the side effect. Respiratory adverse effect of the opioid for the breathlessness, a systemic review and the meta-analysis. Research shows no evidence of the significant or the clinical relevant respiratory adverse effect of the opioid for the chronic breathlessness. Heterogeneity of the design and study population. This low study quality are limitation. Large study design to detect the respiratory adverse effect are needed. Benzodiazepine, low dose of benzodiazepine in the form of the therapeutic trial may be cautiously recommended, particularly when anxiety is prominent and breathlessness appear intractable. Benzodiazepine activating the inhibitory GABA pathway. No evidence of the breathlessness, but may be used for the anxiety. Panic attack, education and reassurance regarding the fear of the suffocation, teaching the breathing technique, cognitive behavior therapy with benzodiazepine, lorazepam 0.5 to 1 milligram, 6 to 8 hourly per oral or the sublingual. Short-acting benzodiazepine is preferred. Patient can be taught to take sublingual lorazepam 0.5 mg during the anxiety attack, midazolam 2.5 to 5 mg 4 hourly subcutaneously for the severe breathlessness episode. Diazepam 2 to 5 mg BD not be used due to the prolonged half-life. Inhaled furosemide. Furosemide may reduce the dyspnea because of its inhibitory effect on the cough reflex, preventive effect on the bronchoconstriction in the asthma, and possible indirect action on sensory nerve ending in the airway epithelium. Evidence remain insufficient to form recommendation for the against the use of inhaled furosemide for the dyspnea according to ASCO guideline. Nebulized furosemide for the management of the dyspnea. This is review article. Systemic review include the 42 study, out of which 39 are RCT and 34 studies in the asthma, 8 study in the healthy subject, and 4 study recruited in both healthy subject and asthma, and 1 study in the COPD. Overall, 3 RCT are relevant to palliative care, 2 performed in COPD and 1 in advanced cancer. 2 study in the COPD shows the effectiveness of the inhaled furosemide in decrease the breathlessness when compared to the placebo. For the people with the advanced cancer, showed no difference in the breathlessness reduction or the isometric arm exercise stays in 15 patients. Oxygen. Mechanism by which supplemental oxygen may be reduce the dyspnea. Reversal of the hypoxemia, reduce the serum lactic acid, reduce the pulmonary artery pressure, reduce the dynamic hyperinflation, reduce the ventilatory muscle and the diaphragmatic fatigue, relieve the bronchial constriction, stimulation of the facial, nasal and pharyngeal receptor, increase the capacity for the exercise training and placebo effect. Oxygen therapy for the dyspnea in the adult. Concurrent systemic review shows the failure to demonstrate a beneficial effect of for the oxygen breathing over the air breathing in the cancer and or the cardiac failure was limited by the small volume of the research study available for the inclusion, the small number of the participants, and by the method used in studies. Interventional review. Oxygen for the breathlessness in the patient with a chronic obstructive pulmonary disease who do not qualify for the home oxygen therapy. This review suggests that oxygen can be relieve breathlessness when given during the exercise to mildly hypoxemic or the non-hypoxemic people with a chronic obstructive pulmonary disease. No evidence indicate that oxygen decreases the breathlessness in the daily life setting. Finding shows that oxygen does not affect the health-related quality of the life. Oxygen for the relief of the dyspnea in the mildly or the non-hypoxemic patient with the cancer, systemic review and meta-analysis. Oxygen failed to improve the dyspnea in the mildly or non-hypoxemic cancer patient. Oxygen did not provide the symptomatic benefit for the cancer patient with a refractory dyspnea. Management of the dyspnea in the advanced cancer according to ASCO guideline. Standards supplemental oxygen should be available for the patient with the hypoxemia who are experiencing dyspnea. SpO2 is less than 90% on the room air. Evidence quality is intermediate and strength of recommendation is moderate. Supplemental oxygen is not recommended when the SpO2 is more than 90%. Evidence quality is intermediate, strength of recommendation is moderate. Time limited therapeutic trial of the high flow nasal cannula oxygen therapy, if available, may be offered to patients who have significantly dyspnea and the hypoxemia despite of standard supplemental oxygen. The evidence of quality is low and strength of recommendation is moderate. Oxygen pros and cons. Pros reverse the hypoxia, improve well-being in the some patient, placebo effect on the patient, relative and professional. And cons are tie patient to the oxygen source, potential loss of the respiratory drive, difficulty in talking, distancing, dry mouth, and the post. Heliox. Heliox is a mixture of the oxygen and the helium, 20 to 28% and 70 to 80% respectively. Increase the SaO2, improve the exercise tolerance, and decrease the dyspnea score in the patient with the lung cancer compared to the oxygen alone. However, it is limited by the expense, combustion logistic, use required non-breathable mass, gas is delivered in the large tank, lack of routine availability, lack of guideline for the patient selection. Heliox and the oxygen and helium gas mixture for the dyspnea. Evidence continue to emerge that heliox can effectively improve the exercise limitation, decrease the work of the breathing, and reduce the dyspnea. Palliative non-invasive ventilation. There are expanding role of the non-invasive ventilation as a form of the palliative ventilatory support. Indication to use NIV acute COPD with the type 2 respiratory failure, hypoxemic cardiogenic pulmonary edema, hypoxemic respiratory failure in the immunocompromised host, advanced neuromuscular disorder. If available, NIV may be offered to patients who have significantly dyspnea despite of standard measure and do not have contraindication. Evidence quality is low and strength of recommendation is moderate from the ASCO guideline. Contraindication of non-invasive ventilation, absolute and relative. Absolute, first is respiratory arrest, unstable cardiorespiratory status, unable to protect airway, impaired swallowing or the coughing, craniofacial trauma, and burn, anatomical lesion of the upper airway. Relative contraindication for the NIV is extreme and anxiety, uncooperative patient, morbid obesity, copious secretion, swallowing impairment, multiple organ failure, need for the continuous or the nearly continuous ventilatory assistance. Palliative sedation, indication, refractory breathlessness, breathlessness which persists despite of optimal medical management of underlying disease is termed as refractory breathlessness. Continuous palliative sedation should be offered to patients with dyspnea that refractory to all standard treatment option and all applicable palliative option and who have expected life expectancy of days. Evidence quality is low and strength of recommendation is moderate from ASCO guideline. Approach to palliative approach to patient, family and friend conversion that include the following: the patient general condition and cause of the distress, acknowledgement that prior treatment has not been successful, current prognosis including the prediction about the survivor, rationale, aims and method available for the use of palliative sedation including the depth of planned sedation, patient monitoring, and the inappropriate and the possibility of the plan weaning off from the sedation and the even discontinuation, alternative treatment option, likelihood that they may relieve the distress and expected survival associated with each, anticipate effect of the sedation including the degree of the reduction of consciousness level and the estimated effect on the mental activities, communication, oral intake, potential risks such as paradoxical agitation, delayed or the inadequate relief, and the possibility hasten the death. Drugs used for the palliative sedation. First is midazolam in acute condition 1 to 5 milligram IV every 5 to 15 minutes as needed until the calm. Continuous infusion initially 1 milligram per hour IV or the subcutaneously, then 0.5 to 5 milligram per hour titrate to the calm. Dose up to the 20 milligram per hour have been used. Disadvantages: risk of paradoxical agitation and delirium. Lorazepam intermittent 1 to 4 milligram IV every 2 to 6 hourly or the 1 to 2 milligram subcutaneously every 6 to 8 hourly. Continuous infusion 0.01 to 0.1 milligram per kg per hour IV or the subcutaneous. Dose up to 10 milligram per hour have been used. Disadvantages: risk of the paradoxical agitation and the delirium. Levomepramazine initial loading dose is 12.5 to 25 milligram subcutaneously IV or IM. Continuous infusion 2 to 3 milligram per hour subcutaneously. Effective dose is 50 to 300 mg daily. Disadvantages: anticholinergic effect, orthostatic hypotension with the rapid IV administration, akathisia, acute dystonic reaction, seizure, and the cardiotoxicity associated with the QT prolongation. Chlorpromazine intermittent 12.5 to 25 milligram IV or the IM every 4 to 12 hourly. Continuous infusion 3 to 5 milligram per hour IV. Usual effective dose is 37 to 150 milligram daily. Rectal 100 milligram every 6 to 12 hourly. Disadvantages: orthostatic hypotension with the rapid IV administration, akathisia, acute dystonic reaction, seizure, and cardiotoxicity associated with the QT prolongation. Phenobarbital initial loading dose is 1 to 3 milligram per kg IV or IM, 100 to 200 mg, repeated after 30 minutes if needed. Continuous infusion 0.5 milligram per kg per hour IV or subcutaneously. may be increased if needed up to the 2400 milligram daily. Disadvantages: hypotension, bradycardia, nausea, and vomiting. Propofol initiate as a continuous infusion at 5 microgram per kg per minute IV and titrate every 5 to 10 minutes in the increment of the 5 to 10 microgram kg per minute. Effective dose range is 5 to 50 microgram kg per minute. Disadvantage: infusion site pain or phlebitis if given via the peripheral vein. Dyspnea crisis, sustained and several resting breathing discomfort that occurs in the patient with the advanced, often life-limiting illness and the caregiver ability to achieve the symptoms relief. Comfort, sudden breathlessness crisis for the caregiver. Comfort is used. C for calm, call for the help, calm the patient. O for observe the patient closely. M for medication like morphine, inhaled bronchodilator or the anxiolytic. F for fan to create the more air movement on the face. O for oxygen, increase the amount of oxygen or the give oxygen order. R means reassurance, help the person relax and provide the reassurance. T for take your time, don't rush. This is summary. Breathlessness is a common and distressing symptom for the patient with the advanced disease. Assessment and management plans should be targeted to the individual patient. A reversible condition contributing to the breathlessness should be addressed, and the patient self-report should be used to determine the severity of symptoms and efficacy of the management plan. No single therapy is likely to resolve the chronic breathlessness, but combination of strategies is likely to improve the burden and the impact of breathlessness. Thank you.
Varun, it was a very good overview right from the beginning. Akshay. So Varun, would you like to take up the summarize, and then we will take. There are a lot of senior people are there who have joined. We would like to take their comments, especially use of morphine for breathlessness and something like that, which is not very common. So Varun, go ahead.
Good morning, ma'am. I'm Dr. Bhavna.
Yes, Dr. Bhavna, please go ahead. Yeah.
Yes, ma'am. I think Varun, maybe some technical issues. He is not
So would you
answering.
like, please.
Actually, Akshay has summarized. Yes, Varun, go ahead.
Good morning, everyone. Breathlessness is very common among the patients of our palliative treatments, and it is a very distressing symptom for the patient and his family. So it is very essential to assess the what are the causes of the breathlessness, and then if any cause are treatable or not, we have to identify that, and after the all the assessment, we have to make a plan of care, whether to treat the patient according to that cause or not, because sometimes at the end of life it is not necessary to treat all the causes of the breathlessness. So whenever possible, we can try to treat that cause, but goal of care discussion is very important, because the comfort care is very essential at the end of life. So, and no single therapy is likely to resolve the chronic breathlessness. So combination of multiple strategy like non-pharmacological and pharmacological and all the things, by combination they can improve the burden and impact of the breathlessness.
Thank you, Dr. Varun. But Dr. Bhavna, you want to add?
Everything they have covered, and Varun has summarized also nicely.
Okay, thank you.
I just want to add that non-pharmacological strategies as the end of life. I am just suggesting we have made some pamphlets to deliver the patient to cover the psychosocial social problem in fact, because they feel whenever there is breathlessness, they have to rush to hospital, because of social issues. People are surrounding them are suggesting to go to take the patient to hospital. So for that, we have prepared a few pamphlets and we are giving to the patient at the when they are approaching this breathlessness.
Very good. I think both this is very, very important situation and very critical situation when most of the unnecessary people rush and then they get intubated and not ventilated. And I think you have prepared the pamphlet. This is very good. So I would like, there are couple of senior people for all of you. I just want to request Dr. Jennifer, Dr. Meenakshi, Dr. Kalpana, and Dr. Nandini, and anyone wants to who is using morphine for breathlessness, so that people can have an idea that how they should use morphine for breathlessness. Dr. Jennifer, can you start, please? And any other comments if you want to do.
Thank you very much for this very good overview. I want to, before touching on morphine, I want to highlight one or two important aspects. One is in the assessment, again, the psychosocial aspects and the impact of the symptom on the patient and family. You did say you prepared a pamphlet, but also to assess how this breathlessness is actually impacting the quality of life of the patient, and thus how we can modify lifestyle changes or make other adjustments that improve quality of life for the patient. And that's why this handheld fan is a very important small thing that can be done, which kind of gives some control over the symptom for the patient. The second thing is, we know that breathlessness in palliative, among palliative care patients, is often multifactorial, some of which are reversible, some of which are irreversible, and there can be new reasons why there can be worsening of the symptoms. So at every point, it is important to reassess what is the additional contributory factor to the symptom and see if that can be reversed, meaning somebody with some baseline breathlessness can get worsened because of a new onset pneumonia, which can be treated and which can reduce that component of breathlessness. So it's important to keep looking out for something which can be corrected. And about oral morphine itself, yes, there is evidence for use, meaning oral or parenteral morphine, depending on the situation and need. And not everybody who has just occasional or exertional breathlessness need to be on continuous morphine, but definitely those who have breathlessness at rest and those who have very intermittent or episodic breathlessness, to try oral morphine at small doses on a PRN basis and then titrate based on the need. I am not sure if we have another session on more opioids and breathlessness, but smaller doses, PRN doses, not as much as we would use for pain, and even the cumulative opioid doses may not need to go more than 20 or 30 mg per day if we are giving opioids only for pain. So these are just some of the points which came to my mind. Thank you.
Thank you, Dr. Jennifer. You have summarized beautifully that all the aspects. I think this is very important aspect. Maybe Dr. Meenakshi and then Dr. Kalpana. I can see Nandini also. Dr. Meenakshi, please.
Yes, ma'am. Just a few practical tips, especially educating the family, especially in patients who have got terminal lung cancer, patients who have got metastasis to the lung, which is increasing at follow-up. That is, patients who have had who have soft tissue sarcoma or carcinoma breast. Those kind of patients, it's better to have these conversations early. Otherwise, they tend to rush to the hospital when an acute episode of breathlessness happens. So, though, like Dr. Jennifer and Dr. Varun earlier had, Dr. Akshay already mentioned that reversible causes of breathlessness have been ruled out. sometimes there is little that can be done because the disease is progressive. So if there are no reversible causes, we might have to quickly institute a pharmacological therapy, which was very nicely elucidated by Dr. Akshay, wherein we start morphine and midazolam either in the subcutaneous route or the intravenous route. However, if the patient is at home and they're not in a position to travel to us, we can dispense when we are on follow-up. When the patients are on follow-up, we should dispense a emergency kit of morphine, and what we do in our center is to send them with lorazepam, the oral preparation. However, it can be crushed and used in the sublingual route as well, and also send them with a haloperidol, so that the combination of these drugs will breathlessness in the with COVID pandemic, everybody has a saturation probe. So invariably, they are all the time looking at the saturation and trying to aim for 99%. So that is another important point. We don't want to target a certain saturation level. It's more important to ask whether the oxygen is really helping with the patient's sensation of breathlessness. So that's another important thing, which all this will require a lot of counseling and talking to the patient and their families. Thank you.
Thank you, Dr. Meenakshi. Thank you very much. I think those very, very important point, and everywhere there is a huge role of counseling, explaining before the situation arises. It's absolutely important that, and it should be in our practice, that anticipating and preparing our patients. So, Nandini, Dr. Kalpana, would you like to add something? Because
hello, good morning, everyone. I just thought of one point wherein all other points of, counseling is taken very well. But one other point which we need to counsel, I think, is the nutrition of the patient, telling them to take small, frequent, calorie-dense meal, which doesn't have too much of carbohydrate, because carbohydrate can increase the carbon dioxide levels. So telling them, to take calorie-dense lipid food may also help in decreasing the perception of dyspnea, especially after meals, which is very, very common. The other point I wanted to, emphasize was there was some talk about the inhalers being used, but very often these patients do not have the capacity to inhale at all. So home nebulizers, I'm sure it was mentioned, but maybe I missed it. So it's important to, tell them that home nebulizers may be the way to go. I think that's, otherwise it was a very all-encompassing talk.
thank you, Dr. Kalpana. Nandini, would you like to add? Then there is a question which I would like to address. Nandini? I think she is logged out. So there is a question for you, Vinay. They are asking that whether we can use weak opioids for. Dr. John probably is asking whether we can use. Dr. John is asking weak opioids, tramadol, to control respiratory distress. Would you like to take this question, Vinay, or Dr. Bhavna? Hello.
Hello. Good morning, ma'am. We can't use weak opioids. It won't help much. Actually, the mechanism I can't explain.
Actually, weak opioids has no role, and there are no evidence, John, for using weak opioids for breathlessness. But definitely, if there is a mild pain and the pain is also a component, and he has never used any analgesics, then tramadol can be used, but as an analgesic, but not as a to relieve breathlessness. So, any other comment anyone wants to take? Give? Dr. Stanley is there? I don't know. Oh. So, if there are no other comments, I think we would like to stop here. And I would like to say that Vinay and Akshay, both have given very comprehensive overview of breathlessness. I think if you will see the slides, everything almost they have covered. Dr. Jennifer, Dr. Meenakshi, Dr. Kalpana, their comments on the subject is also very, very useful. And this is such a great opportunity that one important topic you have learned in just online with such kind of presentations and the comments. So thank you very much, Vinay and Akshay. And thank you, Dr. Jennifer, Meenakshi, Dr. Kalpana, and everyone, those who have participated. John, I think I hope you have received your answer that it will never be, we will not be able to use tramadol only for breathlessness, but if patient is having pain, we can use it when there's no other analgesic tried. And thank you, Archana and Nisha. We all will see you next week before 6:30. Thank you very much. Have a
Thank you.
nice week.